Good morning. So thank you for having me. I love coming to meetings like this and just listening to all of you and being able to share experiences and kind of collectively coming together and thinking about what exactly we can do to address variance. We all know that variance exists. That's just been talked about at length. I'm going to talk a little bit about what drives variation as well, and what exactly we can do about it, and some of the things the MS Society and others are doing to address that. I think you all know who we are, but we've been around since 1956. We're the largest UK charitable funder of MS research. We provide information and support up and down the country, and we also campaign for change as well. So, as we've already discussed, variation absolutely does exist in the treatment, care and support that people with MS receive. This data is taken from My MS, My Needs, which is a survey of about 11,000 people with MS from across the UK, conducted through our membership, but also the UK MS Register. And these are just a couple of findings. But so the diagram on the left shows that if you have a relapsing form of MS, and you're diagnosed recently, you're far more likely to be on a disease-modifying therapy than somebody who was diagnosed more than 10 years ago, despite having a relapsing form of the condition. We found out that a quarter of all people with MS weren't able to get the support they needed to remain physically active. We know there's variance in the key contact for people as well, for their health and care. So unsurprisingly, the majority of people feel that their MS nurse is their key contact. About 20% of people said that their GP was their key contact for health and care. About 15% said their family or friends. But really, really worryingly, 5% of people said nobody at all. So it's 5% of people who feel like they have nobody to turn to help manage their health and care, and that's just unacceptable. And then we also looked at the impact of access to specialists on access to treatments as well. And again, it's as you would expect. So this is just among people with relapsing forms of MS. If people haven't seen a specialist, an MS nurse or a neurologist in the last year, just 12% of people are on a disease-modifying therapy. If you have seen both an MS nurse and a neurologist in the last year, that figure shoots up to 73%. And if they also feel that they've got the right information to make a decision about treatment, that shoots up again to 84%. So clearly access to specialists and information are absolutely critical. And we know that variation in services have an impact too. So this is a lady with MS who came to us to talk about PIP, actually, and what had happened was that their neurologist had moved from their local hospital and she'd been referred to one just down the road. But the services that were on offer in that neighbouring hospital just didn't marry up with her responsibilities, her caring responsibilities in particular. So that means that she's no longer able to get access to a specialist just because of that referral. So I'll talk a little bit more about what drives variation. But I just, at this point, wanted to wholeheartedly agree with the points that were made about looking beyond DMTs. That's really, really important, and particularly PIP. So since personal independence payments were brought in, 9,500 people with MS across the UK have lost financial support in the last 3 years. In England, 1 in 3 people with MS don't have social care support either. And we're doing lots, to campaign for change on those fronts in particular. But particularly around welfare and benefits, that means that people aren't able to get to medical appointments. It means that they're not able to get out and about. People are talking about being trapped in their houses as a result of changes to financial support, and that's really, really just not on, to put it lightly. So thinking about what else drives variation, this is a diagram that the MS Trust did as part of the MS Forward View project a couple of years ago. It's a little bit out of date, but what it does do is illustrate just the complexity of commissioning arrangements for people with MS. And all of these commissioning arrangements just aren't clear either. Adrian talked about a number of initiatives to address that yesterday through like the Neuroscience Service Spec Review and things like that in England. But they've been a long time coming. And in the meantime, that means that the funding arrangements to provide that support are just really unclear. There's also, services provided by charities like us, like therapy centres, etc. Support for charities is also diminishing. It's harder to get funding nowadays to provide that support, and we're being leaned on far more heavily than we were in the past. So again, to look at welfare, we've had a huge increase in helpline calls, specifically around PIP, actually, as a result of those changes. And, you know, that also increases costs as well for organisations like the MS Society. We've talked a lot about this, but there are multiple guidelines out there. There are multiple initiatives out there that seek to identify standards of care, both internationally, nationally. They're often voluntary as well. So again, you know, talking to people with MS about what they ought to be demanding is actually quite difficult, because what do you root that in? There's multiple prescribing guidelines as well. You know, there's the international work that's been done via ECTRIMS, there's the American standards, the ABN standards, we've now got the DMT algorithm as well, so it makes for quite a confusing picture if you're looking about how best to prescribe. And we've talked a bit about data, but then if you've not really got a coherent set of standards, what on earth are we supposed to be collecting and auditing against? That's a real challenge. And we know that behaviour really drives variation as well. So this is just a small piece of work that I won't dwell on too much, but we looked at specifically at what communication needs there are for people with MS in making a decision around disease-modifying therapies. Small piece of work conducted at the beginning of this year. And there were kind of two main factors. One was whether people viewed MS as kind of internal or external to them. So if you haven't really come to terms with your diagnosis, it's going to be an awful lot harder to make a decision about a treatment, never mind just recently after diagnosis. And also, the relationship with your healthcare professional is absolutely critical, and that, you know, that's really quite just common sense. But if you take those things into account, that means both of those factors influence access to DMTs, adherence to treatment as well, and information and support. And that can mean people aren't willing to find out new information about new drugs as well. If you don't feel in control of your MS or being able to make a decision about treatment, it's hugely complex to make that decision. If you don't have enough time with your healthcare specialist to talk through what those options might be, that can really impact you know, the decisions that you then make and the relationship you have with your healthcare professional. And the pattern of initial diagnosis with brief annual reviews sometimes doesn't allow for that relationship to form. And again, you know, who are you looking to when you're making those really complex decisions about treatment? And we also commissioned some work earlier on, a few years ago now actually, about what drives prescribing behaviours as well. Again, I won't dwell on it too much, but overwhelmingly, there was variance in, you know, standards that people were looking at, what influences them in terms of their behaviour, and, you know, what evidence people were looking to. And overwhelmingly, the results just pointed to the fact that we need more clarity and guidance, you know, for people to base their prescribing decisions on, and that really ought to be a UK-wide endeavour. So, what can we do about it? It goes without saying that information for people affected by MS is absolutely critical. We know that that feeds into patient activation and, you know, the services that people receive and the extent to which people will demand more from their MS services as well. We obviously provide a range of resources. We're also testing new models to deliver that information. We're developing an interactive fatigue management tool for people. We did a set of interactive videos on disease-modifying therapies earlier in this year, which were hugely popular. We're also partnering with, you may be aware of the consortium, the Richmond Group, which is a group of long-term charities in England, and they're doing a lot of work around social prescribing, and we're partnering with them to better understand how it might meet the needs of people with multiple long-term conditions. And we also obviously support volunteers as well to provide that support directly. We're at a number of services across the UK directly in clinic to provide direct support there and then to people with MS. And I'll be surprised if nobody mentions this, but obviously there's a huge amount of potential in data and technology to improve treatment, care and support for people with MS. I would say it doesn't come without risk. So there's a real debate to be had around digital literacy and the digital literacy gap and what we do together to address that. But nonetheless, it does allow us to reach people that perhaps don't have access to services currently. We commissioned a piece of work, which is what this is from, with the Nuffield Trust that many of you were involved in. It was all about how can we harness the potential of data and technology to improve health and well-being for people affected by MS. And there are a number of themes that came out. One idea was a suggestion of digital care planning for people, and Adrian alluded to this yesterday in his presentation. We're working through the National Neurological Advisory Group to develop a digital care plan, and we know there are instances of good practice. People are already doing this down in Southampton and so on. We need to improve data sharing across services as well. There's so much data that exists within services, but there are genuine anxieties about what can be shared, what's legal, and that's completely understandable. We're lobbying DH to clarify that, and with Secretary of State Matt Hancock with a real focus on data and tech at the moment, there's perhaps more of a window of opportunity than there was before. And then we've already talked about this, but we absolutely need to develop treatment outcomes that matter to people affected by MS, but that we're all broadly signed up to, because that's going to help us define what standards ought to exist too. Again, I won't dwell on this, but there are a number of opportunities to expand data collection. Through the UK MS Register, we're exploring things like linking Bluteq to the UK MS Register, linking the tissue bank to the UK MS Register. We're also looking at mechanisms that allow for automated collection and analysis, so using things like natural language processing to look at treatment letters and things like that, and inputting that directly into the register. We can use existing data far better. That's partly about sharing, but also freeing up analytical resource to look at that data in more detail. And fundamentally, we want to see new data that matters to people affected by MS. So when we're defining those outcomes, we want people with MS to be involved in that work throughout. We've already talked about standards a little bit. There's actually a huge amount of opportunity available to us next year to work together in defining standards and guidelines and so on. We've got the NICE MS guidelines up for review. Love them or loathe them, they're being opened up for criticism. So that's an opportunity for us to work together to put forward a coherent case for change as well. There's also a neurological plan being developed in Scotland. There's a neurology plan being developed in Wales. There's a neurology plan being developed in Northern Ireland. There's the neuroscience service spec that Adrian talked about. There's neuro service reviews, etc., etc., etc. So there's a number of initiatives going on, but fundamentally we need to work together to input into those and provide a coherent case for change. And we at the MS Society and with the Trust and with others are really keen to facilitate consensus around some of those points to try and improve those policies. We've also worked with the Right Care programme and the MS Trust, the MNDA and Parkinson's UK to develop a combined pathway for progressive conditions. So this will be launched next, this month, we're in November, this month. And basically what it does is identify common standards across different progressive neurological conditions. It includes things like referral to diagnosis, MDTs, mental health support as well. And then it identifies a number of MS-specific areas for improvement too. So things like the role of a specialist nurse, MDTs again, and improving efficiency of DMT provision, for example. And what that will allow is there'll be a clear case for change within that pathway, as well as instances of good practice. And crucially, Right Care also have local implementation teams as well to support any service improvement that you might want to do through that pathway as well. So please, keep an eye out for that. And finally, this is why I love meetings like this. We need to test and share instances of good practice. There's so many examples of innovative practice across the UK. Talk about, there's incredible telemedicine services up in Orkney. That means that, people are able to see their MS nurse when they need to and so on. And we need to learn from those. And we've done a quick scan recently of the evaluation data available for some of those more innovative services, and there really isn't that much out there, to be honest, to help build that case for change that would allow for interventions to be picked up. So we want to improve evaluation of innovative practice. We're open to releasing funds to do that as well through a small service improvement programme. We think we need to work together to better understand the efficiencies that could be made. I'm really looking forward to the work later on about DMT monitoring, to see how that might be done. And also, we just need to continue to talk to one another. So forums like this are incredibly important. We've supported professional forums this year as well. We had a local meeting early this year in East Anglia. That was looking at prescribing, but what it allowed is for people to look at the local data, how that compared to the national average, and build some of those softer relationships between the hubs and spokes in that region. And we need to do more of that. I think that would be a really good outcome from this meeting, actually, is going back to our regional teams and looking at what we might be able to improve on our patch. And then I just wanted to finish on a positive. So this is another person with MS that was in touch with us. And actually, we've moved along a tremendous amount in terms of the treatment, care and support that is available at the moment. But there is work to be done. This person talks about getting the right information and really feeling part of a team with her MS healthcare professional team. And that's what we should really all be aspiring to. So, it is possible. We just need to learn from one another, and there's an awful lot we can do together to make that happen. Thank you.
Any questions for Georgina? Yes.
Thank you very much. I was just wondering if I can ask, in terms of people who access your charity for information, what information formats work best? The reason I ask that is within our trust, I think we're stuck in the format. We need to write a leaflet, right. And actually I don't know what benefit they truly have, and I wonder if you've done any work about, in terms of conveying information, apart from a face and the value of a face-to-face, do other formats sort of compare?
Yeah, I mean, we're actually looking at that at the moment. We've looked at things like the impact of our booklets on increasing patient activation, for example, and they do. But then when you look at engagement in videos and so on, so the videos that I mentioned earlier on, we're doing a follow-up survey with those at the moment, but people were watching those for at least 11 minutes, which is just, unheard of for a video resource. So it suggests that they're really engaging with that material. And we're essentially looking at a digital-first approach, because we think we're going to be able to reach more people through that. So it's a work in progress, to be honest with you, but the online resources that we're developing, particularly that allow for interaction and for people to hear from people like them about decisions that they're also thinking about, seems to be proving the most ultimately engaging.
Any other questions?
The one thing that strikes me is the variability of GP practices and their knowledge about MS, and that in turn influences whether or not they need an earlier assessment, for example, in a team in some instances. What initiatives are there to educate GPs about MS and about really evolving care in a way that's more coordinated between the neuroscience centers, other centers, and the GP practices?
There are a couple of initiatives. I think it's really hard to influence GP practice. GPs are probably going to have one or two people with MS on their books, throughout their career. So it's difficult to make a meaningful change. But in terms of the initiatives that are out there, we've supported a knee module for the Royal College of GPs on MS, and that's had reasonably good pickup. There are a number of local meetings that are held between GP practices. We support those on a regional basis as well. And we've also supported things like red flag systems to be inputted into GP systems as well to flag potential MS diagnoses.
It's a big issue, educating GPs. A lot of the bottlenecks are in the general practice. Paula?
Hi, this isn't targeted at you, Georgina, but it's just a general word of caution. We know that when we introduce some public health interventions, while we might make health generally better, we actually widen the gap between inequality groups. So it's just, for example, the digital,
Yeah.
it might reduce some variations between some groups, but actually might widen some, because we know that some groups aren't as digitally literate as others. And so it's just a word of caution. When we introduce initiatives, we just need to be wary of that and also monitor after we've introduced to see if it's had the effect we expect it to have.
Yeah.
And
No, I completely agree. I'm very aware of ours and others' potential role in widening inequalities, purely because of our reach. And we're thinking through at the moment who and where we might want to partner to target resources. So, for example, we've developed a whole new set of resources around smoking and MS. We've just done a Stoptober campaign to encourage people with MS to quit. And we're looking at things like housing associations and so on to try and push out those public health messages kind of beyond our own channels to try and address some of that. But I completely agree.
The numbers that you showed in your first slide of what people could have access to neurologists, to MS nurses, to GPs or nothing at all. Were there from people that were in contact with the MS Society?
Yeah.
Or, so have you ever done any work with people that don't contact the MS Society, that don't know the MS Society exists, or don't have access to, online resources?
Certainly not on that scale, but we have looked at, for example, again, it comes back to the point of like expanding our reach basically beyond our own channels. Really, I'm cognizant of just the limitations of who we're reaching across the UK. I suppose for me the fact that that was done through the UK MS Register and our memberships, as people either in contact with us or they've signed up to the MS Register, they've probably got higher levels of activation than others, and it's still 5% of people that feel that they've got nobody to turn to. So I think that's probably a bit of a conservative figure, really, when you think about the entirety of the MS population.
Tadeusz Romskis, Swindon. I have a question for both presentations about patient access to the physiotherapy and other therapies. And in our region, in our hospital, we haven't got, waiting time for physiotherapy is 16, 18 weeks. And have you thought about other initiatives, for example, cooperation with the network of the GEM, Snaffles and other, which got across the countries to improve patients' access to the physical exercises and to feel them healthy, to move forward, because it has psychological effect as well, because they exercise in the gym, not in rehabilitation center, with healthy people. Are any ideas for the future in this area?
Well, there are some initiatives we've done in the last kind of year or so, which again it was predominantly online information resources, but we developed a series of videos and online information for people with different levels of disability around what exercises they might be able to undertake. And from the kind of first tranche of that, we developed a whole suite of videos based on what people were telling us about what's most valuable. People were very interested in how best to manage certain symptoms with exercise and so on. So certainly within the information that we provide, we're really interested in ways in which we can build that. And we're also looking at kind of more direct support. For example, being able to refer people to a physical activity specialist through our helpline and things like that.
Sarah, can I put you on the spot? So Sarah's going to tell you about how she found some of her patients that had fallen through the cracks, because there is a way of doing it.
It's a few years ago now, we set up one of our district general hospitals. All the patients were referred into St George's, and so we worked with them to put an MS nurse from St George's into that district general hospital to run a clinic one day a week. And the MS Society were very helpful, our local branch, and they wrote to all the GPs in the area to say that there was this nurse starting a clinic and that if they wanted to refer their patients in, they could. Because we knew that we weren't going to find those patients that had been lost to follow-up without doing that. And we found a significant number of patients that had been diagnosed years ago and been told to go away. There was nothing they could do. or had just felt there was no point in coming to hospital appointments because nothing ever changed. And it was a very easy way of doing it. So we actually ourselves didn't have to do very much at all to find those patients. It was the MS Society local branch that were very helpful in finding them.
So one of the things that could come out of this is a national initiative to find all these people that aren't connected with the services, etc. All right, we run out of time now. Thank you very much, Georgina.